Good morning. I'm Dr. Steve Stites, the Chief Medical Officer here at the University of Kansas Health System. Welcome back to Open Mics with Dr. Stites. And this, my favorite monthly edition of Show Me the Science. More and more people are getting genetic tests, which is great. But who should be reading the test results? And how do those results influence your healthcare or the healthcare of your children? Today we're meeting two genetic counselors who will give us a peek into how they make patients make sense of their own genes. I want to tell you, I had this done. There's a whole long amount of paperwork with a lot of terms and things in there. You're going to have a hard time understanding. You're going to need the help of these good folks. We'll also meet a person who was misdiagnosed based on a genetic test, but ultimately found the right answers once genetic counselors reviewed her story. But first, let's do our morning rounds. We're talking about a case where the FDA approval may have moved faster than the science. About 3 years ago, in February of 2021, a drug branded as Pepaxto got accelerated approval to treat certain patients with multiple myeloma, but less than 1 year later was pulled off the market after a phase 3 randomized controlled trial showed numerically inferior overall survival. In many words, it didn't work. It may have made things worse. After more review, the FDA finalized its decision to withdraw the approval for Pepaxto just last month. Let's talk about it with Dr. Alola Abdallah. How did I do there?
Yeah, that was great.
Spot on?
Yeah,
awesome.
spot on.
A hematologist and oncologist here at the University of Kansas Cancer Center. He's also the director of the Plasma Cell Disorder Clinic, lots of words, but that's a big deal, and the chair of the United States Myeloma Innovations Research Collaborative.
Thank you,
Dr. Abdallah, we're happy
you.
to say this drug was never prescribed to anyone here at the health system because you and your colleagues had concerns when it was approved. Talk to us a little bit about, well, first of all, how do you think it got approved, and what were the concerns that you all had?
Right. First of all, we have to explain to the patients what is the Pepaxto. The Pepaxto is like an alkylating agent. It's like melphalan, the old drug. What they did is a small enhancement for that to make this drug able to access the myeloma cells and focus on some enzymes to dissect it and have concentration to destroy the DNA or break the DNA of the myeloma. So clinically or scientifically, it looks like it's a good drug, more targeted therapy comparing to the melphalan drug. Now, the initial phase, unfortunately, didn't show any impressive results, and we watch any of these drugs in KU Medical Center because we get offers about opening these clinical trials, and the response rate was single agent 8%. That was not really an impressive results. The first phase 2 study that actually led to the accelerated approval was called the Horizon trial. They used the dexamethasone and they added to the melphalan to get a better response rate that barely was 25%. Now, for a lot of people who think that relapsed myeloma, there is not a lot of options. KU was opening a lot of clinical trials that include CAR-T and bispecific. And for us, the CAR-T cells with the bispecific had a response rate that ranged between 70 to 90%.
So it was a lot better than 25%.
Exactly, and it's just like you can't make that comparison. So we have to make a decision about that. Not only that, there was a lot of concern about the side effects, the cytopenia, the white counts being low, the infection rate being high. So the good thing about KU, even with accelerated approval, for a lot of people to know what does that mean, is that instead of going through all the phases, if there is a belief that the FDA can approve the drug earlier or get it access to patients, they can get it approval, and then after the phase 3 trials they have a regular approval for the drug. KU, have like we're a comprehensive cancer center. We have this committee meeting every month, and any drug who get approved before we actually prescribe, we have a meeting about these agents and discuss about the efficacy and the toxicity. And all the committee have disapproved the drug not to be prescribed it, due to the concerns, and also waiting for the phase 3 trial. I will say the word that after that the phase 3 trial, which is the Ocean trial, as you mentioned here, that compare the melphalan with the dexamethasone versus a standard of care, which treatments that sometimes we use POM and Dex, showed unfortunately there was an inferior survival. The fear that we were worried about, and that thankfully led the FDA to withdraw eventually the drug. And we're glad that we did not have any any experience to actually prescribe the medications for our myeloma patients. So I think it's very important to understand the differences, like in comprehensive cancer center like KU Medical Center, to have these committees in order to make sure they review any approval agents before prescribing in the health system.
So you really looked at the studies themselves, looked at what the FDA said, and you think, I'm not sure about this conclusion. Didn't use it. You thought better drugs were out there, better approaches like CAR T therapy, and then a few years later, the FDA said, actually, we were wrong about that prior the earlier authorization.
Correct. Yeah. I mean, I think this is kind of like, and again, it's a group decision for all the hematologist physicians. They look at the studies and they really want to actually give the right decision about this.
So you guys make that, so one individual in your team can't say, well, I'm going to ignore the rest of you and go do it anyway. You make a group decision about
correct.
Like
and that's how we do it. Like, this is a committee that, have been built in order to kind of, develop or actually make sure that these medications have a safety for the patients, first of all. And again, the goal of these treatments in cancer patients, especially myeloma, is to improve the survival, not the opposite.
Yeah, and to think you're going to give somebody who's a bad drug who's already got multiple myeloma, that's not the best plan there. So now you're involved in a lot of research in cellular therapies, CAR T, and then something called T-cell engagers. Yeah. So, I don't think T-cells are getting married. So you're going to have to talk to us a little bit about what that means.
Sure. I mean, so the CAR T-cell, we know a lot about it. The T-cell engagers, it's like an antibody that is similar to the CAR T-cell, have the same mechanism, but instead of taking your own T cells outside the body, we just give that antibody inside to inject it. And what it will do, it will take your own original T cells to attack the myeloma cells. So just like that middleman who just introduced the T cells to attack the myeloma cells. So you're kind of like saving like one step. So why is it important? I think the importance of that because there's issues about giving the CAR T cell, because of the manufacturing, the timing, the slot availability. But this drug is like off the shelf. So having this treatment as a mechanism, with this mechanism of action, kind of with also the good response rate, kind of like make it more easier and accessible for myeloma patients.
And so, do you have any drug that you're working on you think is going to come to market soon, or can you even say anything like that?
I'm sorry?
Do you have any one of those drugs you've been researching that you think may come and be released by the FDA or anything? Or
so far, I mean, there is, we're hoping, but it's going to take a little bit of a while. Well, the CAR T have the targeted, which is BCMA, which is really working good, and the bispecific. And we have another bispecific that work against GPRC5D, but we are expecting there is going to be a new CAR T that works against the GPRC5D, so we will add more treatments. Yeah. But the main excitement, I think, is going to be when we start seeing the CAR T moving a little bit earlier lines, which I think the FDA will approve it in the next couple months. Standard
of care, because the standard of first-line therapy as opposed to third or fourth-line rescue therapy.
Exactly, and I think that's going to be really needed, and it's a big excitement for our KU patients because, we have been struggling because patients getting many lines of therapy, it's very difficult to get them to treatment, so I think this will be very an excitement news for our patients. Not only just great response rate, quality of life. It's a one-time treatment, by the way.
Yeah, that's awesome. Well, thank you very much for being with us today, and we sure look forward to having you back to talk to us about those new ways CAR T therapy is going to be used.
No problem.
Thanks for your time today. All right, now you may have heard of the BRCA, or BRCA, how do we say it? BRCA gene? BRCA gene. Okay, I didn't see that extra A in there, but I'm going to believe you. And it's linked to the higher risk of breast cancer. Or maybe the APOE gene, and it's linked to Alzheimer's disease. Or to the CFTR gene, linked to cystic fibrosis, a world in which I do my clinical work. These links might make you assume that it's as simple as, well, if I have a certain gene, therefore I will develop a certain condition. But it's really not that straightforward. We probably tell you a lot of stories about that. But which is why we need genetic counselors like two of the great folks who are sitting with me here today. Shobana Kubendrun.
That is it.
All right, I got it right today. Okay, I'm on a roll. Is the manager of the Genetic Counseling Service here at the University of Kansas Health System. She works with Katie Nelson, also a genetic counselor. Guys, thank you for being here today. It's awesome that you're here.
Thanks for having us.
And to help us to understand what it's like to meeting with a genetic counselor, we're joined by Vicki Cohen. Vicki is someone who is on track to get unnecessary cancer screenings and surgery until someone decided her genes needed a closer look. Shobana, before we get to Vicki's case in particular, tell us, what do genetic counselors do?
Genetic counselors, we are part of a healthcare team, a vital healthcare service, and our role is to help with the analysis and communication of complex genetic information and combine it with personalized counseling. So whenever it's not just about disclosure of test results or reading from a genetic test report, it combines understanding what that information might mean for a family or individual. Because when you hear something is genetic, it just feels inherently so personal. And then your immediate thoughts go to, is this something I'm going to pass on? How does this impact my family? So to combine that with the risk assessment, another component is, it's about the genetic test result, but what does it mean for you? And communicating that in a meaningful way that resonates with that individual's perceptions, beliefs. For example, if I say something has a 50-50 risk, an individual may view it as a glass half empty or a glass half full. So that's what genetic counselors do. Even as we are disclosing the result, we're trying to assess and understand how that information might be perceived, because if we can help you adapt to that information, then you will be empowered to make those meaningful changes that are consistent for you. And to do that, we go through 2 years of rigorous master's level training where we understand the science of genetics and the art of counseling, and we bring that as a service with a healthcare team where components of this are provided, and we try to bring that together. And I'd love for Katie to speak more on the cancer genetic counseling aspect, because there are many components to it.
All right, you go.
So specifically for cancer genetic counseling and testing, it's assessing an individual's personal and family history of cancer. And that's not just immediate family members, that extends to cousins, great aunts, great uncles, so your grandparents' siblings. We're asking a lot of detailed information that not always does individuals have that information readily available. And so going through the importance of that information and how that can impact someone's recommendation of how much testing would be helpful to them, but then also giving that individual a choice and personalizing that option and how much testing they may want, if it's more targeted to what their current cancer diagnosis is, or if they want to get as much information as they can from this testing. But knowing that the more genes, the more testing that we do, the more complex those results can be when we get them back.
Right, and I think it's fair to say that, and you guys correct me if I'm wrong, but genes tell us one part of the story, but there's other determinants of your health. I think about our CF patients, and I have twins, and they have the exact same genetic structure, right? They're identical twins, but one of them has a very bad presentation of their CF, and the other's doing really well. And it's amazing how you see that. There's a lot of variability sometimes in how these things penetrate, so we speak. So, Vicki, nearly 6 years ago, you got a genetic test. Based on the results, you were told you had FAP, familial adenomatous polyposis. Okay, what that really says is you have a whole lot of polyps in your colon. It covers your colon, and pretty much those things can easily develop into cancer at some point. How did you feel when you got those genetic test results?
Frankly, I was bewildered because I've had regular colonoscopies, and I never had a colon that was covered with
filled
polyps.
with adenomatous polyps.
Never, ever. So I really didn't. I was really bewildered. I thought, well, all right. I mean, maybe this is what the genetic stuff says, but I just never developed that. So. So the first step, that happened was that I got a phone call. I was actually on my way to an airport coming home, and it was advised that I get genetic counseling testing because I had had 2 cancers in my history. I had a breast cancer in like 2020, I think, and then I had a colon cancer in 2012.
So that would send up a lot of alarm bells for, I think, our genetic counseling. Like, okay, what's the funny gene?
I thought I was one and done.
Yes.
I really did. I recovered. Everything was fine. Everything was caught really early. I never had chemo. I just had the radiation for the breast cancer, which the level of breast cancer I had, I probably wouldn't have had even the radiation now.
Right.
Cancer's
so different.
come a long way.
It's evolved a lot.
Yeah, if you're going to have a cancer, this is when to have it, and come here for sure. So, so I did the genetic counseling, and but then that led me. So those were facts. And I'm a big believer in facts, because if I have facts, it's like, okay, what do I do?
I can make a real decision, as opposed to people not telling me the truth.
Yeah, but I wasn't in a position to make a decision, sort of. Can I name names of doctors?
Yes, you may.
Okay,
you go
so
right
the
ahead.
first person I saw was Dr. Carol Fabian.
Yes.
And she's very direct.
She's very factual, yes,
and
she
I
is.
said, well, what should I do? And she said, I want you to get I would get a hysterectomy, and to prevent an ovarian cancer, and I also want you to see the high-risk internal medicine GI doctor, Dr. A.J. Bansal. So I did the first thing, that was that, and then I met with Dr. Bansal. He's the one that thought I had FAP. And he drew it out, all the things that this could affect, including my eyes. I had an opportunity to get connected to Dr. Wishna.
Yes.
I just kept meeting wonderful doctors. And I thought, well, maybe it looks like I have FAP, but somehow or another I've kind of emerged.
Yeah, I didn't get the polyps, which is a little funny.
Yeah, so, but then it turns out I get a phone call from Dr. Bansal, and he asked me, he goes, do you know what chromosomes are? Oh, well, before that, Katie wanted to there was more testing to be done, and went into more detail, and, and I actually thought, well, this is something that KU wants to do because they like, research. It's really important, research.
In this case, it was a research for an N of 1 U.
Yeah. So I thought, all right, why not? Why not offer myself up, to be a subject for this? But so I did, but I really didn't understand I didn't understand the dilemma that the team was having. And then I get a phone call from Dr. Bansal. He asked me, he said, do you know what chromosomes are? And I said, kind of. And he said, well, every chromosome has a long arm and a short arm, and I have this 5q deletion. He explained it to me, and he said there was a molecular meeting. You were the subject of it, and we think.
So there's a party, and you didn't get invited to the party, but you heard about the party.
I heard about the party, but the party was essential. It was everything, because Dr. Barry Skickney was there, and he became my hematologist. Well, he's the one that said, I think this is MDS, myelodysplastic syndrome. So then I had to have, and also at some point I had a conversation with Katie. I remember I was driving, when she called, and I really wanted to resist all of this. I didn't want to do any of it. And she said, you could develop a leukemia.
Big word.
I know. And it was very scary. So.
But good news is that they said, okay, you don't really have FAP,
right,
but you might have this other disease, and that's something we need to follow and work with you on. And therapies are completely different.
Yeah.
So you could have gone from having your colon out, which wouldn't have helped anything.
No.
To really watching your bone marrow, which helps a whole lot of things.
Definitely. And I had the bone marrow aspiration and more facts. And I think this molecular meeting stuff, I think in the earlier presentation, there was talk about
a big meeting where the docs all come together and decide on a course of therapy.
And maybe that's how come this place does what they do as well as they do it, because
we have people from all over the country and world sometimes as part of those meetings, and lots of folks who are actively engaged in the front lines of research in those areas, and so I think that makes a difference for outcomes and how patients do. So that's a remarkable story. Okay, so first of all, Katie, talk to us a little bit now about what the challenges were in interpreting a multi-gene panel test on someone like this, and I think that you kind of know her and her story.
Yes. So I was really introduced to Vicki's case through that molecular tumor board, and being able to be a part of a multidisciplinary team, that had her gastroenterologist, Dr. Bansal, hematologist, molecular geneticist, molecular biologists, and genetic counselors on that, all coming together and saying, yes, we don't think this is familial adenomatous polyposis. It has to be something else, most likely hematology related. And how do we confirm that? How do we prove it? And so my role was really to recommend additional testing to be able to confirm what was causing this abnormal genetic test, and what other testing can help figure out what was the actual concern. And so being able to take that initial step with Vicki and saying, these are some other testing that we can do to help answer this question. And I think it's very hard to, on one hand, give reassurance that we're not concerned about the familial adenomatous polyposis. I'm not concerned about your colon. Your colon's doing great, but we are concerned still about another cancer risk, and having to balance that reassurance, but also why are we doing additional testing? Why is this relevant or important to your care? And some patients do have that resistance because one more thing to be worried about, and what is there to do
And
then?
it's understanding you had both breast and colon cancer still, so how did that tie together with what we did find, or did it tie together?
So it was trying to explain that even though the familial adenomatous polyposis causes a risk for colon cancer,
Right.
I don't think that did not actually explain Vicky's colon cancer.
Right, plus she didn't have adenomatous polyps under
She-
colonoscopy, so
yeah.
that doesn't really track.
She had less than 10 polyps at the time, and we expect to have thousands of polyps in individuals with FAP. So going back and forth between, yes, I understand why I was suspicious at first, but it's not matching what we would expect to see.
Yeah.
And so what other testing can we
you do to
do,
go-
and then to navigate you to the right people? And Vicky's exactly right. Dr. Skickney being in that room, once we did this additional testing, already having someone that was familiar with Vicky to be able to send her to and say, Dr.
Yeah.
Skickney, like, will you follow Vicky? Because you're already intimately.
Well, I can just hear Dr. Skickney's voice. I've known him for many, many years. Whoa! I could quite hit the intonation. I know that very well. So, Shabana, talk to us a little bit about how this story tells us about how genetic counselors fit in the cancer center and really in many diseases.
Oh, absolutely. No, that's, the Cancer Center and the health system as a whole are taking genetics not just into oncology, but cardiology, and looking at the need across many different.
Cystic fibrosis.
Cystic fibrosis.
I'm just saying.
I laughed. Now you got to give me what I want.
No, you didn't laugh the first time. That was a great joke. T-cell engagers. I'm not getting married.
I'll laugh.
Nothing.
Give me some more staffing. Yeah, there we go. No, but in all honesty, so this is an exciting time to be at the health system and the Cancer Center. We have 7 genetic counselors just dedicated for oncology, and they work with every discipline within oncology. They attend tumor boards, review these cases, so you can be reassured that these tumor boards have the input from genetic counselors who review the cases and determine this case needs further evaluation or testing or counseling. So that's one component. The other components of genetic counseling, of course, you can always refer to us, and we will see them via telehealth. The other component by which genetic counseling, our service, is extending our expertise is by supporting physicians and nurse practitioners with genetic risk assessment at point of care. So we know the staffing that we have is not going to meet all the needs of genetic testing and counseling across the Cancer Center. So we are working with our high-risk clinics and the newly created Division of Precision Medicine with Dr. Weitzel, Dr. Nye. There's many providers that Dr. Bonsall, the ones that we've already mentioned on the tumor board. So there's going to be, over the next few months, an alignment of sorts between the KU, the academic portion of it, and then the health system portion, to bring and increase access to genetic testing and counseling. And some of the other things which you've already showcased in the show are things like the All of Us study.
Yeah, that's a big darn
That's
deal.
yeah. So
That's a really big deal.
I'm trying to remember if they covered it in the show, but 2% of the time, I mean, it is a research study, right? But 2% of the time, they will find genetic changes in genes that increase the risk for cancer.
Yeah.
So so I see a lot of synergy coming together at this time in alignment and increasing services through various service models. So, and genetic counselors are here to work as part of that multidisciplinary team.
Well, and I think what All of Us really points to this precision medicine becoming the future of medicine, and what that really means is that therapies will be directed and tailored for you, both on your genetic determinants, and we're going to also have to look at social determinants of health and try and figure out how those two things really come together. Is there a lot of demand for what you're doing?
Yes. So speaking of, remember,
Is this
I
where
said
you're
I have a
trying to
few.
advocate?
I'm
Yeah, I
trying to
gotcha, I gotcha.
advocate.
I hear
Yeah.
ya.
My staffing needs are going to come to your table soon. So we are requesting additional staffing, mainly for the direct care, and then the other component is just different service delivery models that we're looking at.
Yeah, and I think the real thing is that what's going to happen, and you guys comment on this, is we understand the impact of human genome on disease. We'll really be always asking the question, what are your genetics like, and what does that mean for what therapies you should get? Is that fair?
Yeah. There are genetic components, so that's the next level of, I feel, in genetics, is just that genetic risk stratification. We have genes that have genetic changes that significantly increase your risk, like with the BRCA, and then you have there's another field which is evolving polygenic risk scores, in which multiple different changes cumulatively increase the risk. So the way I see it is like a buffet menu with many different options, and depending on what you get from that buffet, it changes your outcome and what you eat and how you develop. So those are the different ways. I'm excited to see how the health system and the cancer center
And how
develops
the whole
it.
field of medicine evolves. And I don't, even in my own area in cystic fibrosis, we say, well, this is your CF gene, but we know there's 5 or 6 other determinants on your genome that affect how much that defect impacts how well you do. Not to mention your lifestyle, whether you smoke, how well you eat, do you exercise, do you do your therapies, and so all those things come together to determine how well folks do. So Katie, because there's often a hereditary side, conditions can get passed on to kids. How do you talk to families about children?
Yes, so I think one way I like to phrase it is all information is good information, because it tells us how to take care of you and your family better. So even though I feel like as a parent, all we want to do is protect our kids from having to deal with these concerns, to say this is something that can be passed on. Doing genetic testing can help your kids protect themselves in equipping them with this information so that they can take those steps with their healthcare provider and make sure that they're getting the correct screening to better monitor or prevent cancer risk. So I don't think any family wants to hear this news that there's a mutation in their family and that other relatives can be at risk for cancer. But whether we do this testing or not, there's still that risk.
Yeah, it still exists. Can it help you to know? I know some people want to live without that knowledge, and some people want to live with the knowledge. The question is, it's a choice that an individual can make. Now, do you have children?
I do, but both of them were adopted, so
Okay.
that was
off the table for that.
Exactly.
How about other family members?
I have other family members who have had breast cancer situations. There hasn't, I don't know. I don't know if I want to say there's been a lot of cancer in my family. I don't really think there has. But
those are all questions you had to think about and consider, though.
Yeah.
Yeah, it's really important. Now, Shabana, are you doing anything to help us know that we're going to have equitable access for all to have genetic information?
Absolutely a priority for the Cancer Center. So we have partnerships with community organizations and clinics. In fact, Katie is part of one of them too, that very directly it's for increasing access within the underserved and uninsured communities as well. Katie?
So I also work with the Center of Genetic Services and Health Equity, providing care to community hospitals, specifically the KC Care Clinic, and offering individuals free genetic counseling and testing to underserved populations. And we have great community engagement on both the Missouri and Kansas side to get individuals not only the genetic counseling and testing service, but also follow-up care. What are resources in their area to actually get the screening that they may need? Because it doesn't just end with the test.
Yeah, you bet.
Well, what do we do with that information to actually protect individuals?
Yeah.
Now, there was a graphic we were going to show. We haven't done that one yet. Do you guys want to talk our way through what this graphic means? One of you, this is, I think, even Vicky's pedigree.
So this is just outlining how extensive we go through family history as genetic counselors. So it's not just immediate relatives, siblings, parents, it's cousins, it's great aunts and great uncles, or your grandparents' siblings. And even though individuals don't always know all that information in that first appointment, to get individuals to realize that that amount of family history can impact what recommendations are for testing or what screening recommendations just based on family history can help with.
Yeah, it's a big darn deal. All right. Well, we're going to be here to help answer your questions. Great program so far. We're going to switch gears for just a moment. So send your questions into the info on your screen. You can send them into the YouTube or Facebook or the X platform or emailing the Medical News Network. Let's check in with Doc Hawk today.
Yeah.
Doc Hawk, how are we doing?
Hi, we're doing good. You know, COVID admissions are down just a little bit, under 20. That's good. We're at 18 active admissions for COVID patients, but we also have some other viruses that we're talking about, namely influenza and RSV as well, Steve. So.
Yeah, and we got a graph that this last week, for the first time since the beginning of the pandemic, we've had more influenza admissions than COVID admissions.
Yeah, it's pretty crazy. Just like you said, you can see on that graphic there on the far right of your screen, the COVID is in green, influenza in blue, and RSV in orange, that the influenza admissions are more than the COVID admissions right now. So we will say that overall influenza activity around the nation is decreasing, but certainly in some regions or pockets there is also stable or slightly increased activity compared to the rest of the nation. Here we have our influenza cases, both inpatient and outpatient testing. Those are driven largely by increasing influenza B cases. So influenza A has been the predominant, is typically the predominant early on. That has been the predominant virus throughout the respiratory viral season. We are seeing increases in B now, and the influenza A cases overall have been relatively stable. There also were 2 pediatric deaths nationally last week, and we would say those were influenza B cases as well. So overall, influenza testing does remain high, increasing percentage positive, and that is concerning because we know that the number of people being tested is still great as well. So when you have a lot of people being tested and the percent positive high, that means that there just are a lot of numbers of infections. So we have 15% right now at the health system compared to 9 to 10% 4 or 5 weeks ago. And right now I think the national average is about 15% or 15% positive. So just a little bit higher, just on par with the national data as well.
All right, excellent. And just to say out loud, today a story broke about a man getting multiple COVID vaccinations in Germany.
Yeah.
How crazy is this crazy does, but talk to me about what do you think about that?
You know, again, we discussed this just a little bit. So there was a record of this gentleman getting, there were actually verified records of him getting at least over 100 vaccination doses. He was investigated for fraud because they thought he was selling vaccination cards to people. The investigation for fraud turned up nothing. The prosecutors didn't charge anything. When news broke of that, researchers reached out to this person, and by the time they had reached out to the person, he had actually received 217 vaccine doses over 29 months. The first 103 or so were within 9 months. You know, what they found was that there were no adverse side effects. It didn't increase or decrease his immune system, you know, any more than somebody who's gotten the normal number of doses or the recommended number of doses. But I think this is an N of 1, so a very small number. But even with that many doses, we can say there were no ill side effects of this from getting all these vaccine doses. We certainly wouldn't recommend that. We would stay with the CDC guidance and ACIP guidance and recommend just the recommended number of doses. And again, for right now, if you are immune compromised and you received your updated COVID vaccine at least 8 weeks ago, you can get that second dose. If you are over 65 and you have received the updated COVID vaccine at least 4 months ago, it is recommended that you get that dose as well. So.
Yeah, that's a lot of shots. I think I would always feel crummy because I was always getting a vaccine shot.
Mm-hmm. Yeah, I couldn't even believe there wasn't mention of that, because even a lot of people, and maybe not with the first or second, but maybe with the third or vice versa, you know, there's no rhyme or reason necessarily. But I think to your point, yeah, you know, getting that malaise or getting some fever and chills at nights or even some local site pain, but they did not report any of that. So it's pretty interesting.
Well, crazy as crazy does. All right, Alexis Del Smith is in our studio watching for questions from our community. Alexis, how are we doing?
Did you give me a new last name, Alexis Del Smith?
Oh, good. I know I said Del Cid, but man, my words are slurred this morning. You ever have one of those days where your tongue is just tied, you can't quite get it out? I think I was up too late doing work.
My husband's going to have a lot of questions about that.
Well, you know, there you go. Watch out.
We have a great question coming in. This is from Jeremy Yenser. He writes, when you get genetic testing done, do the results keep giving information over time as there are new insights or medical discoveries, or is it more a point-in-time test?
You guys are both you're both shaking your head yes. So
Well, yes and no. It's not a one and done. You know, when you get genetic testing, you get 3 types of results. One is you get a result that says this is definitely a genetic change, and we've seen it many times in different populations. That's important. And it confirms that this is going to increase your chance for a condition by a range of numbers, 60 to 80%, because it's well studied. So it's not definitive, but it gives you at least a range of risk associated with that condition. The middle, so that's 30% of the time in general for any condition. And then another 30, you get what's called variations of uncertain significance, which is, it's a maybe answer. The way I tell families, it's like a recipe for chocolate chip cookie that has, instead of 2 teaspoons of baking soda, it's 2.5 teaspoons.
I love chocolate chip cookies.
I know. And then you're like, well, is this going to change how the cookie crumbles? We don't know. We haven't seen it before. We might have to make that recipe to determine it.
You're doing good here.
I love recipes.
You're carrying this right out there.
Yeah, so that's how, no, it's a valid question. I want families to know, you know, if you're listening to this, that is where the genetic counselors, we spend hours going down that rabbit hole, digging information that is not going to be on that genetic test report. So definitely genetic testing, you know, you can go through your trusted healthcare provider, your primary care OB, family specialist, med-onc. Definitely, you know, we want to make sure that you get testing and then know that genetic counselors are here to help you with the interpretation of both the positive and the negative. And because even if it's negative, but you still have a clinical condition, how do we interpret that in the context of your family history, like Vicky's case?
Yeah. You know, it's interesting because my report was like 10 or 11, 12 pages long. It was very long. And I could I'm in the field, right? And I could understand just a small portion of it. It wasn't until I got to talk to the genetic counselor that I actually understood what it all said. It made a huge difference.
We use a lot of analogies. I could do a whole show on different analogies used in genetic counseling.
Are you going to be using ingredients and cooking?
Yeah, I am.
I want some of those cookies. Okay, Alexis. I got your name right that time.
You did. Thank you.
Really.
Thank you, Dr. Stites. We have a specific question from one of our loyal viewers named Susan on Facebook. It's so specific. Susan, we see your question. We're going to ask our experts off air, and then we will see how we can help you. So wanted to acknowledge that. I have a question from Marie. Marie texted and wants to know, she writes, my parents did 23andMe. We got a whole packet, about 100 pages long, of what genes the family carries. Is that just as reliable?
No, that's a very good question. 23andMe is something that can give you, interesting information about your ancestry. Sometimes it can give some health information, but all of that has to be validated by a clinical lab. There has been studies that say that 23andMe can have a 40% false positive rate. And the way I like to think of it is these clinical labs that we use in our clinics, they have to read a book or a page 1,000 times to be able to say that this is truly a change or a risk for an individual. Labs that are direct to consumer don't have that rigorous of validation. They can see something once and say, yep, we found it, but then when we relook at it through a lab, that wasn't actually there. It was misread. So the difference between reading a page once and saying, oh, I think I found a mistake, and reading a page 1,000 times and saying, yes, this is definitely a concern for an individual is different.
That's super interesting because so many people do these 23andMe or Ancestry. Carol has a question. Carol wants to know, if you could wave a magic wand and give everyone in the world a genetic test, what would you order be tested, and what do you think it would change about the world?
Oh, wow. That's a big question.
Yeah, magic wand. So I'll put a plug in for the All of Us study with the KU. It is a research study. It is looking at whole genome, so both the genes that are actually protein coding and the non-protein coding. It's a research basis, so it is available. Go through the informed consent to find out what you can and cannot find through that. But the information, so I would then go back to Carol and ask, what is the information you would like to know? This goes back to my introduction, risk perception. Mm-hmm. What is your concern? What is your perception of risk? Because based on that, as clinical genetic counselors, we can help find the right test that will help address those questions and discuss with you what it can and cannot answer. So as far as, testing that's available, I mean, we have routinely whole genome sequencing that is clinically available. The question is, what is your medical history? Does it correlate with what the findings are? It's like getting a whole body MRI. How do I interpret it if I don't know the symptoms? Well, you can. If it's like truly,
if it's overwhelming.
If it's overwhelming, you'll find it, but you're going to find a lot of gray spots. So that's the DNA, all that genetic variation. We still don't know what it means, and that's one of the reasons why we need a lot of participants in the All of Us study.
It is. The whole All of Us study makes a huge difference because it's going to be the first thing of its kind.
Right. Yeah. No, I'm not officially affiliated, but I will plug in for that.
No, I officially am affiliated.
Yeah, there you go.
It's really important, and we're going to start enrolling patients here pretty soon, I think. So.
Yeah. No, that's good.
Alexis, last question, I think.
Ralph has a question. This one's about COVID. Ralph writes, I'm confused. I received my COVID shot in September. I'm over 65. Does that mean I need another shot?
Oh, Hawkeye, they just changed the recommendations here last weekend.
Yeah, I mean, the wording is that the CDC changed the recommendation from may to should. If you're over 65, you should receive a second dose. And this is just based on updated data, understanding that some of the immunity does wane a little bit, especially for those most at risk, which is those over 60 or over 65. And so in going with that recommendation, in accordance with that recommendation, we would say you should get another dose of the vaccine.
Yeah, I think it sounds like basically you need to get it every 6 months or so is what it feels like they're landing on, because there's an increased risk of bad outcomes for those over the age of 65 and especially over 75. And so based on that, it feels like they're just saying, look, you need to get 2 shots here, not 1.
Yeah, and we know activity is still fairly high, although lower than it was, but what we always say is really discuss that with your medical team or your medical provider and always have a plan. If you have symptoms, test early. You may have to test 2 or 3 times if you're doing it at home, and have a plan to see if you can get on that oral antiviral that is proven to help reduce your chance of going to the hospital as well. So.
All right, this has been an outstanding discussion. I am so thankful for all of you being here today. We're going to hear some final thoughts. I'm going to ask Vicki if you'd give us yours first.
Final thoughts. So I don't know a lot about genetics, but some of the things that I think I learned is that you can have I think this is correct, a genotype, but not necessarily have the phenotype.
Right. The expression of it. Yeah.
Right, and I think that you were talking about with the CF twins. Yeah. So that's really curious to me, sort of how that happens. I have a question, like, was I born, I mean, I don't know if there's an answer to this. Was I born with this, or is this something that happened during the course of my lifetime, and what might have impacted my genes that might have, turned them on or kept them dormant or turned them off?
And we see that a lot in patients. You're born in a certain way, and suddenly things get turned on. And so what we know is it takes both genes, your environment, and you to define how diseases are going to present in you.
Yeah.
Final thoughts.
I want to bring it back to what you said earlier, that it's not always just clear that the one test is going to give you the answer. In Vicki's situation, we had to do something called a karyotype, because the testing that she had looked at what I would say one chapter in the book, and that chapter was missing. And the question from me, the genetic counselor, was, well, how many other chapters are missing? And so you can see from this visual that APC gene, that one lab was only able to say that one chapter 40, was gone. but we also saw chapter 43 and 45 gone as well. And so having to do another test to see, oh, you actually have missings chapter 20 through 50. So the way that these tests can be ordered, there may have to be alternate ways that we can look at genetic information. One test does not do everything. So being able to know what other options are there is something to lean on genetic counselors for, to say, what can we do for this patient to answer this question better, or why are we seeing this result?
Yeah, that's a great explanation. Shabana, final thoughts today?
Genetic counselors are your trusted source of genetic information, just like your show is a trusted venue for all the updates. And it's going to be a good phase at the health system at KU. We're going to have genetics interface with every area of medicine.
Yeah, it's going to be awesome. Doc Hawk?
Yeah, great discussion, great topic. We've come a astronomical way since Gregor Mendel was first doing his experiments and reporting on his findings. So we have great resources here. Please talk to your doctors if there are concerns. We obviously our genetic counseling center and our physicians and our medicine teams are ready to help you out. And then on the subject of vaccinations, obviously we heard about this gentleman who received multiple vaccines, no adverse side effects. Overall, the vaccines that are currently on the market are extremely safe and they are extremely effective. Please be up to date with your vaccines. We know that there are different outbreaks going on around the country and around the nation, and the best thing you can do is keep yourself and your family protected, and vaccines are the best way to do that.
This is a great time to be in medicine, because I think we're truly heading a real golden era where therapy is tailored so much more specifically for you, based upon not only your own genes, but how you are in the world and the social determinants, how well you eat, and different things, how much stress do you have. And what we know is that all of these things combine to make you. And our job in healthcare is to try and take care of you. And by you, we mean all of you. And so when you see the all of us thing come out and we get started rolling it, we want to love to have you be a part of that, because we do want to take care of all of you, your genetics and all parts of you. So thanks for watching and listening today. Faith, Hope, and Science. You heard it here today. You hear it next week too.
Back-to-back diagnoses led this patient to develop her own workout routine. I'm Alexis Del Cid. On the next All Things Heart, how her workout that she launched is so successful, other cardiologists prescribe it to their patients.
Subscribe to our morning medical update and Open Mics with Dr. Stites podcasts. Now everywhere podcasts are available.